Hi, uh, today's topic is surgery of the left ventricular outflow tract. Anatomical substrate. Normal left ventricular outflow tract. The left ventricular outflow tract is a complex structure that includes the aortic valve, the sinuses of Valsalva, and the subvalvular fibromuscular outflow from the left ventricle. The aortic root is a dynamic unit in which all components contribute to the opening and closure of the aortic valve and are continuously changing during a cardiac cycle in response to the aortic pressure, the ventricular pressure, and the ventricular geometry. Congenital or acquired anomalies of any component of the aortic root can eventually lead to aortic valve dysfunction. The normal aortic valve is made of three cusps that have a crescenting shape, from which the name semilunar valve originates. There is a small fibrous thickening in the middle of the free edge of each cusp, nodule of Arantius. The cusps overlap in their closed position. The closer line produced by the apposition of the adjacent cusps is visible on their ventricular surface 2-3 mm from the free edge. The three cusps are attached to the aortic wall in a crescentic manner without a circular structure that could be assimilated to a ring or an annulus. The cusps are separated by the commissures. Above the valve, the aortic valve is expanded to form the sinuses of Valsalva. The dilatation of the sinuses ends at the level of the tip of the commissures. At that level, there is a discrete ridge marking the sinotubular junction of the aorta. In its ventricular aspect, the insertion of the valve delineates three triangular areas between each cusp where the aortic valve is seen. These triangles separate the left ventricular outflow tract from the pericardial cavity. The sinuses and the cusps are named according to the origin of the coronary arteries, namely the left, right, and non-coronary sinuses and cusps. In a normal three-leaflet aortic valve, the length of the free edge of each cusp equals the diameter of the aorta. The combined length of the free edge of the three cusps equals the circumference of the aorta at the sinotubular junction. In a bicuspid valve, the combined length of the free edge is at best twice the diameter of the aorta. The orifice is therefore significantly smaller than the circumference of the aorta. A precise knowledge of the anatomy of the aortic root and its relationship with the surrounding cardiac structures is of great importance to the surgeon. This is particularly true for the repair of congenital malformations necessitating the enlargement of the left ventricular outflow tract. The understanding of the hinge mechanism of the left and right fibrous trigones in the subaortic region would also improve the surgery for left ventricular outflow tract obstruction. The entire right coronary sinus lies adjacent to the right ventricular outflow tract. Inferiorly, it relates to the interventricular septum. The non-coronary sinus lies adjacent to the right and the left atrial chambers and the interatrial septum. Inferiorly, the commissure between the right and non-coronary cusps is related to the membranous septum and to the penetrating atrioventricular bundle. The left part of the non-coronary sinus inserts into the anterior mitral leaflet. The commissure between the non-coronary and the left coronary leaflets is positioned above the area of aortic mitral valve continuity. The left coronary sinus lies adjacent to the left atrium on the right and to the lateral aspect of the base of the left ventricle to the left. Inferiorly, It relates to the anterior mitral leaflet of the mitral valve. To the right, this is the only part of the aortic root that doesn't relate to the cardiac chamber but to the free wall of the left ventricle. The commissure between the left and the right coronary cusps lies adjacent to the corresponding commissure of the pulmonary valve, and there is an area of dense fibrous tissue between these commissures. In this figure number 37.1, here we see in the middle aortic valve, in the top pulmonary valve, in the right tricuspid valve, and in the down left mitral valve. In this picture of figure 37.2, we see two coronary arteries, left coronary artery and right coronary artery, and also bundle of hairs near the in the back of the non-coronary cusp, and the membranous septum near the right and non-coronary cusp commissures, mitral anteromitral leaflet in the non-coronary cusp and left coronary cusp, and also we can see the another structures in this picture. And I'm continuing to read the topic: abnormal left ventricular outflow tract. Obstruction to the left ventricular outflow tract may be found at valvular, subvalvular, supravalvular, or combined levels. The left ventricular outflow tract obstruction may be isolated or associated with other defects such as coarctation of the aorta, interruption of the aortic arch, ventricular septal defect, pulmonary stenosis, patent ductus arteriosus, mitral valve abnormalities, or less commonly atrioventricular septal defects, atrial septal defects, and anomalies of the pulmonary venous return. The association of aortic stenosis with parachute mitral valve and coarctation of the aorta is known as the Shawn syndrome. Aortic valve regurgitation is rarely an isolated congenital lesion. More often, the aortic regurgitation develops as a complication of valvular or subvalvular aortic stenosis. It can also be associated with other congenital cardiac anomalies such as subarterial ventricular septal defects. Aortic valve regurgitation is more frequently an acquired disease due to an inflammatory or degenerative process. It may also be related to a dilated aortic root in connective tissue disorders. Nowadays, balloon valvuloplasty and surgical valvulotomy is the main cause of aortic regurgitation. Congenital valvular aortic stenosis. The various anatomical forms of aortic valve stenosis have been well described. The valve is bicuspid in about 70% of cases. The leaflets, which are usually thickened, are oriented either laterally with the commissures positioned anteriorly and posteriorly, or they are arranged anteroposteriorly with the commissures to the right and to the left. A fibrous ridge or rough, which varies in length and thickness, is often present on one of the two cusps. There are usually variable degrees of peripheral fusion of one or both commissures. Stenosis can occur without commissural fusion simply as a result of thickened leaflets and a bicuspid configuration. If the free edges of both thickened bicuspid leaflets are taut and equal in length to the diameter of the aortic root, they cannot open and they produce a significant gradient. Stenosis may result from the unequal size of the cusps, which is frequently seen in bicuspid aortic valves. When the commissures are situated in an anteroposterior plane, the coronary arteries usually arise from each